afternoon, everyone. Thank you so much for being here during your lunch. I know how busy you all are as fighters. I'm going to, don't worry, I know how valuable your time is. I'm going to go through a lot of these beginning slides very quickly so we can get down to the important meat of our conversation. And so I'm sure many of you, most of you are aware that the Center for Youth Wellness was founded in 2012 by Dr. Nadine Burke Harris, who is now serving as our Surgeon General for the state of California. We're very proud to have had the opportunity to have worked with her and let her set the stage and the goal for our organization's continued journey. We really believe and want to fulfill the promises and thought leadership that Nadine set with helping communities heal and recover from adverse experiences. And we believe that that really starts with providers screening for ACEs and making appropriate referrals and contacts for families. And then for that, those services to be continued and to wrap around throughout the community in partnership with payers like Blue Cross and through online resource organizations like Unite Us or Aunt Bertha, those types of things. So that's really the also the precipice of how we came to work together with you all for this project was through a grant and partnership with Blue Cross. Today we're going to have a very, very, very brief review of ACEs science because again, we know that you have had many other ACEs trainings or have the opportunity to go into depth on the science component. What we really want to talk about are the best practices for screening in medical settings, and then really what those components are. I had put together some information about the reimbursement through AB 340, which is the bill that funds screening and reimbursement for ACEs, but you've had a wonderful presentation from Erica this morning. I'll just highlight the codes that need to be utilized for billing, and that's it. So let's dive in. So I want to talk for just a moment about the concept of the biological mechanism for toxic stress. And so I'm sure you've heard this, but when a child or a family experiences adverse events in their lives without protective factors and particularly when they have some predisposed vulnerability, they may experience toxic stress. And that toxic stress, when occurring on a chronic basis, creates dysregulation in the neuroendocrine and immune systems. So we can see clinical implications where there's a disruption in the endocrine system, the metabolic system, and even the reproductive system. We may see neurologic, psychiatric, or behavioral changes related to the neuro system, and we may see immune, inflammatory, or cardiovascular changes with regard to the immune system. And eventually, if those changes persist over time, you can actually see changes to the DNA or epigenetic changes that can be passed on to children. And so we have a multi-generational impact of ACEs. We think it's important when we talk about screening for ACEs to address the variability in symptomatology. And so in this diagram, you'll see the child on the left has experienced multiple ACEs within their lifetime. They don't experience any clinical manifestations, or they grow up into adulthood with no symptoms. They have a healthy lifestyle, but they still develop disease. They still may develop disease, a disability, and experience early death, or they may go on to have a completely healthy life. The line in the middle is the child who also had those same experiences of ACEs, but did have symptoms. And so you can see there the symptoms that are highlighted. Again, the disruption in the neuroendocrine or immune systems. And that may lead them to develop unhealthy lifestyles or pursue more health risk behaviors. And so they may also proceed through life and have an early death. So we do think it's important for you to consider symptoms that may be associated with toxic stress, and we'll go over that more and how that impacts your screening methodology in just a few minutes. So the 10 core ACEs that we traditionally talk about are the ones that were originally identified in the Onda and Folletti study. So the 10 core ACEs have to do with abuse, both physical, emotional, and sexual, neglect, both physical and emotional, and items of household instability, including mental illness in the home, having an incarcerated relative, partner violence, mothers being treated violently were initially what was identified in the study, but now in our surveys and in practice, we like to talk about that as partner violence, substance abuse in the household, and then divorce was again also indicated in the original study, but now we talk about in the context of parental separation or multiple households. In addition to that, on both the ACE-Q, which is approved for use in adults in the state of California, as well as the PEARLS tool, which is approved under AB 340 in the state of California for children and adolescents, there are the 10 core ACEs and additional adversities captured on the tool. And those include community and school violence, racism, social injustice and discrimination, housing instability, food instability, separation from family or caregiver, and this is related more towards not parental conflict or disruption, but foster care, immigration or deportation, and then caregiver serious illness and caregiver death. These are the symptoms that have been associated with toxic stress based on the literature, and we could provide that information and the details for you. And I will say, we use the term clinical symptoms loosely here, if you will. It's too hard to say manifestations. So just bear with us. We aren't saying that the presence of asthma itself is associated with ACEs or toxic stress, but we are saying that frequent asthma exacerbations can be linked with toxic stress, as well as frequent eczema, colds, infections, pneumonia, and that's looking at the inflammatory cascade of responses. For the endocrine system, we see diabetes, difficulty with weight gain or obesity, frequent abdominal pain, constipation. Many of these symptoms or diagnoses you all will know well as sort of those vague symptoms that some patients present with, like abdominal pain or headaches, that it could be worked up to the max and include MRIs and endoscopy and that type of thing. And we're asking that maybe you consider looking at some of those in conjunction with adverse childhood experiences to see if that might be the link between those symptoms and possible reasoning or rationale for the experiences. And then some of the neuro responses we can see depression, anxiety, impulsivity, again, frequent headaches or migraines in the younger child, inconsolable crying, difficulty sleeping, and those go on. So at the Center for Youth Wellness, we've had the wonderful opportunity to partner with multiple organizations across the country in screening efforts, and we started an additional organization called NPPC, which is the National Pediatric Practice collaborative. And so we enlisted about 10 clinics to work with us to do a pilot study on ACEs implementation. And what we're sharing today are the best practices we've learned from those organizations across the country in varied settings, both rural, large academic, inner city clinics, um, school-based clinics, employee-based clinics even. So I think you'll find that we do have multiple um, thoughts and opportunities to share throughout the country from our learnings. If I could just ask if you are, if you're able to mute yourselves while we go through the rest of the presentation, that would be really helpful. I'm getting a little bit of feedback. Okay, so the key components to successful screening: establish a rationale. Why do you want to start screening? What is your thought process? Erica shared a really great rationale for screening, and that is you get enhanced reimbursement. We know that there are financial incentives for almost everything that we do, in addition to the fact that it may be the right thing to do or maybe the best thing to do for our patients. Being able to be successful in that many times involves reimbursement or some financial means to offset your screening efforts and staff time. We want to identify the screening tool to be utilized. Again, in this case, you'll need to think about the target population you're starting with, because if you're going to be addressing peds, which we have heard may be the direction you want to go, you are going to start using, we would strongly recommend, that is, you start using the PEARLS tool, because that is the only tool that is eligible for reimbursement for AB 340. If you're going to start with the adults, we would strongly recommend you utilize the ACE tool. Again, I'll go over that more in detail in a moment. We know that you need to start with a population that you're screening, a small subpopulation, and a screening interval. Again, for participants in California, that screening interval is really best identified and has been sort of laid out in the Surgeon General's protocol or workflow to be the well child visits. We recommend that you outline your workflow in great detail, how the tool is actually going to be handed out and delivered to the patient and then back to the provider, how the screening will be recorded in your electronic health record, etc. We also recommend that you have a screening algorithm. This helps to make sure that there's a standard approach among all the providers as you screen patients. It also helps to provide some anticipation for the staff to carry out the next set of activities that the provider deems appropriate, but it gives them some guidance on what to expect next. We also encourage you to develop a referral and intervention plan. That is generally incorporated into part of the scoring algorithm, but it's important, very, very important thing to discuss, and then establish data measures and a reporting process to, again, collect information in your EHR and also track how well you're doing with your screening efforts. So let's get down to business. My screen is frozen. Here we go. We're going to talk for a minute about a screening rationale within your practice. We learned from working with our NPDC clients that primary care, particularly pediatrics, is the ideal setting for health promotion of this kind. Particularly when you think about screening for toxic stress in the context of the medical home. We want families to approach you all not only when they are sick, but really to come to the clinic to pursue their health and wellness. And so having the conversation with patients and families about how toxic stress can impact their health in the long term is a really good way to help them make the connection between what your efforts are striving for and goals that they can set. We also know that there is evidence that early detection can prevent those negative health outcomes, particularly when we talk about building resilience or addressing some of the chronic diseases in the context of toxic stress. We also feel, which I've already mentioned, that discussing adverse experiences is a wonderful opportunity for the provider-patient relationship. Patient families often hold their providers in high regard, and so the fact that you are interested in what has occurred in their life helps to reinforce that our experiences are important. It helps to reinforce that rapport that you may already have with your patient families, or certainly can help to build that. And we also have learned through our experiences that patient families feel like having their provider ask about ACEs is in itself an intervention. So they already feel like just by you asking them about that you've helped them in some way. So I want to make sure that you hear that, because we feel that's an important thing to consider, as we hear that one of the most common barriers to screening is really that fear and concern around what are we going to do when we have all of these positive ACE scores from patient families. And we'll talk more about that, but just also keep in mind, families do feel like they have had an intervention just by you simply asking. So talking a little more about screening rationale, some things to consider within your clinic. Do you currently have an abundance of resources, say for adolescents, or great community partnerships with Boys and Girls Clubs, or that type of thing, where that might be a great place for you to start your screening population, or designate adolescents as a target screening population? Maybe you have a lot of resources in your community around early childhood intervention or parenting classes. So that may be a community resource or partnership that you'd like to strengthen and highlight for your target considerations. You may want to leverage a previous quality improvement initiative. So maybe you have a really great process around screening for autism using your MCHAT and your ages and stages questionnaires. Can you model your ACEs screening after that initiative? Or can you align it with a patient-centered medical home designation? Maybe you have a special condition population that you're working on around kids with ADHD. So would you want to screen those kids first for your target population? Again, just thinking about things that could reinforce your screening rationale. Do you want to just start with early childhood screening because your organization is committed to early intervention whenever possible? And then thinking about your target population, maybe consider ages where there are fewer immunizations or screening efforts. We have many clinics that have chosen the 3-month or 36-month time interval because there are fewer immunizations, or even starting at the 5, 7, and 9, as those are back to school populations, and those visits tend to be well utilized and have a lower no-show rate. Maybe you have a higher high resource service community. So maybe you have children that seem to be coming in, or a particular population that are scheduling a lot of visits or have a lot of concerns, and you'd like to address that specific population to get a higher number of visits in those early screening efforts. I'm presenting both the ACE-Q child tool, which is, I apologize, this one has actually, is the basis and has been adopted for the adult population, as well as the Pearls tool. I know those are hard to see, but they are both readily available at the ACEs Aware website, and we can provide those links for you as well. We think it's important to talk about the fact that when using either the Pearls or the ACE-Q for adults, you do have the option to use the identified or de-identified tool. And when I say de-identified, it's not what we commonly think of in the medical practice. You still will have the patient's name and identifiers on the actual tool or linked in some way so that you can record it within the medical record. When we talk about de-identified in the context of adverse childhood experiences, we literally mean that for the core 10 ACEs, we are not asking yes and no as to which particular experience a patient may have. We're asking for the total number of experiences in the 10 core ACEs, and we refer to that here where you see this box for section 1. We also ask that families tabulate their total number of experiences in section 2, where those additional adversities are represented, and capture that in the box to the right here, and then add those two scores together for their total score. When we have worked with practices who have chosen not to use the de-identified tool, we see a very high rate. So with questions for every item that say have your child's parents or guardians been separated or divorced in the last 12 months, yes or no, we tend to see a high prevalence of no's all the way down the questionnaire, or a high refusal rate. And I think this is important for you all to consider, and I'm sure there are red flags going up in your mind. There certainly were when I first started working in the field of adverse childhood experiences with regard to this concept around identified and de-identified scored tools. I was afraid that we would miss a child that may be experiencing abuse or neglect, well, if we didn't ask the yes or no questions. And while I still feel that is critically important as a nurse and a social worker, I also have come to the realization that, number one, this tool itself, the Pearls tool and the ACE-Q, have been designed not to survey or assess the experience of ACEs. What we're truly looking for is a risk stratification for toxic stress. And when you take that into consideration and really embrace that, it feels okay to ask for the total score. And secondly, you all already do an amazing job every day screening for abuse and neglect. And we would ask that you continue to use your clinical judgment and the tools that you already have in place to assess for those things. And really keep in mind that this tool is to look at and look for toxic stress and its clinical manifestations. So when we talk about using a screening workflow, we literally want you to process and map out who's going to administer the tool, and then how's it going to get completed, how's it going to get scored, who's going to assess for symptoms, who's going to make the referral designation. And the reason those things are so important that we clarify those roles is because there's specific training that needs to occur based on each person's role. And so in many clinics that we work with, we have scripting for medical assistants and staff that are handing out the tool, because explaining how to fill out the tool is critically important, as we just discussed with regard to the de-identified nature of the tool. And then we have scripting for the medical providers who may be reviewing the scores. How do you talk to a patient family about when they have a positive score, or when they have a low risk score and you just want to provide some anticipatory guidance about ACEs, toxic stress, and the impact they can have on your body. So again, having clearly defined processes and roles are key to an successful implementation. That's a mouthful to me today for some reason. We also know that the best practice is to include a three-tiered approach for referral and intervention. I'm going to go over that a little bit clearer through this scoring algorithm and visual. So when we say a three-tier approach, we mean literally stratifying patients between a low risk, an intermediate, and a high risk designation, and then having clear actionable items that staff and providers will take based on each of these classifications. So typically we see, and in the scoring algorithm recommended or provided through the state, through the ACEs Aware website, we see designation of low risk with a score of 0 and no health problems or clinical manifestations based on this list. And we will provide you a copy of this so that you can look at in more detail. These are the symptoms that I went over earlier. They've just been divided up into a checklist based on age differentiation as well. So no symptoms, score of 0. We would recommend that you use some patient education handouts around ACEs and what is toxic stress, just to provide that anticipatory guidance. For an intermediate risk, we would see a score of 1 to 3 on the PEARLS tool with no symptoms or health problems. One possible intervention would then be to provide patient education and anticipatory guidance on ACEs, toxic stress, and building protective factors or resilience. We have 7 handouts on the 7 domains of wellness that build protective factors that we will be sharing with you in English and Spanish for use however you see fit. But they are wonderful patient education tools. In addition to that, you may want to send your patient families to a care coordinator or your social worker to screen for some additional community resources needed. Your medical assistant could ask, is there anything else that we could help your family with today? And then you could plug into a resource like a Unite Us to look for some of those community-based resources. And then certainly we would ask that the provider schedule follow-up as they deem necessary for that patient at the intermediate risk. For patients that would be classified as high risk, we would see those as patients having a score of 1 to 3 on their PEARLS tool and experiencing at least one of the health symptoms on this checklist, or patients with a score of 4 or more with or without symptoms. In this instance, we know that the patient has met sort of the threshold from the Onda and Folletti study, where we see a score of 4 or more associated with multiple long-term health outcomes that are negative, or we're seeing a score of 1 to 3 and a possible clinical manifestation. So in the interim of additional information, we would ask that you stratify those patients as high risk, and then go ahead and provide them with anticipatory guidance on how to relieve toxic stress and how to build those clinical protective factors, and then have your social workers see this patient and see if there are additional referrals needed with regard to trauma-informed therapeutic services, and so on. We would also ask for you to strongly consider, if there are clinical manifestations, that you schedule the patient for a follow-up to monitor how they're doing, and also to help close the loop on any of those referrals, to get those patients back in front of you and to help reinforce how important you feel it is that they address the toxic stress by coming back to visit with them. And we know when patient families have a follow-up visit or hear that their providers feel the need to schedule a follow-up visit, that oftentimes they take the advice given at that initial visit more seriously. I'm just going to quickly highlight here that in many cases, the symptom assessment is critically important, because if you just take a look at this score in itself, of a 3-year-old little girl who had a score on her ACE-Q or PEARLS of 2, that would be an intermediate risk. But when you put that together with the clinical picture that she's been seen 4 times in the past 6 months for stomach aches, and then the fact that the mom, so we've got that vague abdominal pain complaint, and then the mom shares with the medical assistant that she's been called from the preschool several times related to biting or behavioral incidents. We have 2 possible symptoms related to toxic stress. That changes the picture for this child from a score of an intermediate risk at 2 to a score of 2 plus symptoms and making her higher risk, or would pique your clinical curiosity for further assessment, and most likely referral to your social work services. We also recommend that if at all possible, you align your ACE-Q or ACE's implementation with a performance improvement strategy or methodology. We know that when you use a PDCA or a PI method along with this, it helps to standardize your implementation process and provide structure on how you're going to take steps for screening implementation. We also know that the screening initiative itself aligns with your Joint Commission accreditation if you have ambulatory or hospital designation. It aligns with HRSA if you're a federally qualified health center, and it also aligns with your patient-centered medical home designation. In addition to that, you can capitalize on some of the PCMH activities, such as the pre-visit planning, to talk about and reinforce your target population screening initiatives early on. So when you do that pre-visit planning, you can say, hey, remember everyone, we're screening 3-year-olds at well child visits. Do we have any of those on the schedule for tomorrow? It works well when you incorporate it with your referral tracking as well as your huddle. We cannot emphasize enough how critically important it is to embed screening documentation into your electronic medical record. This is an example from one of the practices we have worked with in the past. Don't worry, these are test patients and test providers, so no PHI is being shared inappropriately here, but we would ask that you consider adding your Part 1 and Part 2 scores, whether or not the patient family refused or declined, and also look at a place where you can capture symptomatology as well. The 4 performance measures that we feel are critical for tracking your success, again, would be looking at, and this is an example if you're screening patients of ages 3, 4, and 5, that you look at the percent of patients that were screened in a given month, the percent of patients with a positive screen in a given month, those patients that had a positive screen that had a referral for additional services, and the percent of patients refusing screening. All of these individual 4 indicators will help to tell you different, or help to guide you in different ways of how you can improve your screening efforts, and we'd be happy to share some further feedback on how looking at that data can help your practice. I'm quickly just going to go over this last slide, and then I want to open up for questions. I know I've been speaking very quickly, and I want to give you all a chance to ask anything that is a hot and burning topic for you. When you begin, after you've completed your attestation through the state of California, you can begin billing. And so it's important that you know the 2 billing codes, or HCPCS codes, that are required for successful reimbursement. So whether you're screening adults or children, if they have a high-risk score, a score of 4 or more, you'll use the HCPCS code G9919 on that visit. and that will afford you the reimbursement of $29 for that screening. If the screening reveals a score of 0 to 3 or lower risk um, from the scoring algorithm we shared earlier, you'll use the HCPCS code G9920. Again, both of these can be applied to infants through adults over the age of 65 annually, and you will be reimbursed annually for each patient member $29. So every little bit helps, right? So I think that's important for you all to know. Again, Erica did a great job sharing that. So I'm going to turn it over. I'm going to start my video so you can see my face, and I'll stop my share so we have a bigger screen for everyone's faces to ask questions. Please feel free to unmute yourself, or you can put your questions in the chat. And if I need to go back to a slide, I'm happy to do that. I know there's no way that I dazzled you all with my brilliance and speaking 90 miles an hour. So please feel free to take this time to stop us and ask us questions. On our next training, go ahead. I think I might have a question for Dr. Ungar.
I just wanted to say thank you for the overview. This was very helpful. I just had a question. I think I had to jump out in and out a little bit, but I believe, the focus I think of today's was on pediatrics. But can you speak to, I believe there's initiative to do this screening on the adults as well. And can you speak to that a little bit on the benefit of doing it in the adult population and the application of it a little bit? I don't know if this is going to be covered in the next training or not,
Sure, absolutely. So in the adult population, we can cover this more in the next training. The ACE-Q tool is the approved tool from the state of California, and we see benefits with regard to chronic disease management, quite frankly. When you have patients with diabetes, helping them to link their adverse experiences with the changes in their life expectancy related to that, or the leading causes of death and ACEs, we often see that it really helps adults to be motivated to make some of those changes that you have earnestly been working on with them, maybe around losing weight, addressing high blood pressure, or again, lowering your A1C. It helps to bridge the mind-body link for adults, and we find helps to lead them to be more ready for change. If you think about Prochaska's model for readiness to change, it can certainly help get them to the next level. The reimbursement for adults does occur, I believe, once in a lifetime at and after 65. It is reimbursed annually for those 0 to 18. And I believe it's reimbursed annually from 18 to 64. So again, there's health benefits for your patient families and a financial incentive.
Thank you so much.
Thank you. We certainly will be happy to send these slides out to you after the training. And let me just share this with you. If nothing else, maybe you all can react to the thought around this. For our next training, the goal or the intended discussion was around scripting, literally how to talk to patient families about ACEs, and to provide you with some scripting around the patient handouts or patient education tools that we'll be providing to the clinic. So really getting down in the nitty-gritty about how you can use the patient ed collateral pieces that we're providing for you, and just some quick points on what you or your staff can say when engaging patient families around handing out the tool and then actually using the patient ed materials. Does that sound like that would be helpful to you, or are there items that you feel like would be more helpful in our next and final session?
I want to say something.
All right. Molly, Daniel, Erica, would anyone like to have any last word? We've got about 5 minutes left, or any other final questions or comments?
I don't think so. Thank you, Carissa. This is Erica again. Just want to emphasize to everybody on the call, if you're having any trouble accessing the ACEs Aware training, or if there's anything that comes up, like I said, my email will be in the slides that Molly will be sharing with the group. So please don't hesitate to reach out.
I said something, but no.
I thank you again for your time, everyone. We're going to give you 5 minutes back in your very busy day, and we just want to also thank you for all the wonderful work you do, and tell you how much we appreciate the way you serve our children and families in the Antelope Valley area. And we appreciate you. Have a great day and a great week.
Thank you.